So I'm Charlotte Fowler. I'm here because I'm the chair of the Nuclear Medicine Specialty Committee. I'm trying to tell everybody about how great nuclear medicine is as a career. We need to get more people into the specialty because it's a growth area. So I'll hand over to Amy.
Hi, I'm Amy Eccles. I'm a radionuclide radiology consultant based at Imperial College in London, and I'm the current radionuclide radiology advisor for the Royal College of Radiologists. I also sit within the BNMS Council, and I'm part of the SAC and STC with Charlotte and various different people, depending on which meeting I'm in. And so I'm involved in the training and development of radionuclide radiology, but also its link with nuclear medicine physician training and therapeutic aspects of nuclear medicine as well. And so I think I'm going to talk about trying to balance your career and your life. Do as I say, not as I do, from that point of view.
Oh, great. Hesham.
Hi everyone, my name is Hesham Dyab. I just finished my nuclear medicine and radiology training and newly appointed as a consultant. I will be talking about what is the training will be like, what you should expect, what challenges you might face during the training.
Thanks, Hesham, and congratulations.
Thank you.
Sweni, who's still in the thick of it.
Yes. Hello, I'm Sweni. I'm ST8 nuclear medicine trainee, so on the combined radiology nuclear medicine training program in my final year. So just one more year to go. But I'm here to talk about exactly what Hesham is going to talk about, basically how the training program is, what it entails, why I like it, and what are the challenges, how is the day-to-day balance, etc.
Brilliant. Thanks, everybody. And sorry, can you just introduce yourself quickly?
Yeah, my name is Gang Lintet, one of the IMT1 in the James Badger Hospital, Norfolk. I just want to explore what is the nuclear medicine, and I want to explore more. And it might be one of the specialties I might interested.
Okay, well, it's great to have you here. Thank you. So I want to talk about nuclear medicine, which sort of boils down to functional imaging and tailored therapies, and I think is a really great career. So I'm going to cover very quickly what is nuclear medicine and give some examples of that, and also talk about some career structure before I hand over to other people to talk about sort of their experiences. So what is nuclear medicine? It's the diagnostic and therapeutic use of radioisotopes in medicine. The radioactive atoms that we use are unstable and they emit energy, and sometimes, depending on what the characteristics and size of the atom is, also particles. And we can use those. We can use those by utilizing the radiation that is released to form functional imaging. And we can use the particles that can be emitted from certain ones for molecular radiotherapy. So we've got this two aspects, and that actually runs through the different career paths that we have, because the functional imaging is done by nuclear medicine physicians, but also radionuclide radiologists like Amy and also like me. And then the particle side of things is generally done by nuclear medicine physicians. Unless, like Amy, you've got special training in it as well. So in the radiopharmacy, the chemistry is actually used to form a radiotracer connecting a chosen isotope to a carrier molecule, which concentrates in a particular organ or biological process depending on how the tracer has been designed. And the isotope is chosen for its characteristics. Some isotopes emit radiation that can be very nicely used for image production, and others have emissions that can be used for therapy, as I said. So here's the list of all the different medical specialties from the JRCPTB, and you can see that nuclear medicine is one of them. So it is a physicianly specialty, and the areas where we have imaging. I'm just overlaid the kind of traces that we use and the studies that we can utilize. You can see basically covers a very wide range of different medical areas, and that's due to the breadth of the traces that we use. So some of our traces are very basic. For example, the first tracer that was ever used was iodine for the thyroid, and that was just the molecule itself is involved in the biology of the process, so nothing very fancy is needed. But some involve very complex sort of nanotechnology, as in a DAT scan used for Parkinson's disease, where clever scientists have worked out how to actually produce a ligand that attaches to the presynaptic molecule, and that can be used for DAT scan imaging for Parkinson's disease. So the range of traces is extraordinary, and that is kind of what gives the specialty the breadth and the interest, really. So if a process is tracer avid, we can use a diagnostic isotope, either a gamma ray or a positron for staging. And then we can add a therapeutic isotope, either a beta or alpha emitter, for treatment. And we can combine those two stages together. We can use, for example, iodine-125 to image thyroid cancer in a patient, but then switch to using iodine-131 for therapy. And there are other examples of that, where we use one isotope to image and another isotope to treat. And that is called theranostics, and a very exciting part of our work. And of course, nuclear medicine images that people are familiar with is sort of bone scans, for example. I'm not going to run through all of them, don't worry. But this is done with a sort of sliding planar gamma camera. But with recent technology, there has been an expansion of what can be done. So we now are having hybrid imaging, where you get this sort of holy grail of exquisite anatomy and overlaid function to really indicate where the problem is. So we're adding function to form, as it were. And this is research sort of led basis now, but in the future we'll be able to overlay coronary anatomy to myocardial perfusion images and work out exactly which is the culprit stenosis for particular problems with angina to help guide intervention. So the technology is really racing ahead. So nuclear medicine physician as a career combines the skills of a physiological imager with targeted therapies. How does it differ from radiology? Well, there are many similarities, and in fact, you can't do nuclear medicine now as a standalone specialty. All nuclear medicine physicians now are also radiologists. But the nuclear medicine physician side of things that we are talking about now is emphasizing the kind of strong therapeutic role, and the fact that nuclear medicine physicians have admitting rights, run their own clinics, so they have to have strong clinical skills to give the necessary holistic care. Consultants, once trained, are licensed by the Department of Health, which is an RSAC license, so the Administration of Radioactive Substances Advisory Committee, and the requirements of that sort of underpins all the training that is required and provided for nuclear medicine trainees. So in terms of the pros and cons, it's a small specialty but has got big growth needs. It's well centered between different patient types, so we deal with neonates to ancient geriatric patients. One of the great advantages from many perspectives is that because the radiochemistry labs don't tend to work overnight, there's no on-call. And one of the big pros for me is that because it's a small specialty, we're very dependent on our specialist society. Amy mentioned the BNMS, which is an absolutely fantastic UK-based coming together of our specialty, and is kind of multi-professional, and great parties and marvelous kind of research is presented there, and it's always really great. I guess the cons is the long training, takes 6 years to train, and quite a lot of exams. People applying will have done their MRCP, but then there's also FRCR for radiology and the postgraduate diploma in nuclear medicine. So it's not for the faint-hearted in terms of exams, but on the plus side, you end up being probably one of the best trained doctors. The curriculum is at the JRCPT website, and the recruitment is being run as normal. It's actually the recruitment runs jointly with clinical radiology, and applications are being accepted now. So just to run through the training quickly, people will have done core medical training and MRCP, or equivalents from surgical and pediatric backgrounds. There is a competitive recruitment at ST3 level, and there is then a 6 years program, and the first 3 years concentrates predominantly on clinical radiology with FRCR, and the final 3 years is dominated by nuclear medicine, and there's a switch between the two. So in the first 3 years you do 20% nuclear medicine, and in the final 3 years you do clinical radiology. And when you come out at the end of that with all the qualifications and satisfactory training, then you are dual CCT'd in nuclear medicine and clinical radiology, and the opportunities will be wide. Why do I love it? It's never boring. It's constantly evolving because of the development of new tracers. It's intellectually challenging and rewarding. Great people work in nuclear medicine, and we have a very wide range of patients and referrers. And so for that reason, I have found it a wonderful career. Okay, I'm going to therefore hand over. What should we do? Should we talk to Amy first? Yeah.
Thanks, Charlotte. I think you've explained the career path really well. So I've done a similar training program to Charlotte in that I'm a clinical radiologist. I think, if I'm being honest, I've probably had a slightly portfolio career and training, because after I CCT'd as a radionuclide radiologist, so I'm on the specialist register with the GMC as a clinical radiologist, I then developed my therapy skills under the mentorship of nuclear medicine physicians within my consultant posts in the teaching hospitals where I've worked. So I've now developed my nuclear medicine therapy aspects as I've grown as a consultant, not just my waistline, but hopefully my experience and my training as well. But I'll be completely honest, if I had my time again, I'd be doing what Sweni had done and what Hesham has done, and what you as internal medicine trainees are doing. And I would have done my MRCP, I think, before coming into nuclear medicine, but that wasn't something I was particularly aware of. So, we're striking whilst the iron's hot with this recording and with these conversations to sort of get people who may be interested and maybe has actually heard of nuclear medicine ahead of them making long-term career choices about their subspecialty, etc. So I'm going to talk a little bit about what I do on a day-to-day basis in terms of my practice and how it's balanced with the clinical radiology training and work that I do. So I work in a teaching hospital in London. We are a large molecular radiotherapy service for the Northwest London sector and a little bit beyond as well. So we perform iodine therapies, we perform lutetium dotatate therapies. We were part of the early access medicine scheme for lutetium PSMA, which is a new therapeutic molecular radiotherapy for prostate cancer. We do SERT therapies for liver tumours, and we support the oncology service for the malignant iodine therapies as well. And that's the therapeutic aspect of what I do. But I also do ultrasound, I do CT as a general radiologist, and then I also report PET CT, as Charlotte's talked about, the sort of functional imaging, and I do general nuclear medicine as well. So I do, out of my 40 hours a week, for my NHS practice, I do 4 hours of ultrasound. I do 2 hours sort of job planned in terms of CT, and the rest is nuclear medicine or special or SPA time, which allows me to develop my CPD to help train others as well. So I'm an educational supervisor and support my colleagues in research, do some research myself, audit, etc., etc. So it's a busy time. It's definitely changed since when I was training. So the curriculum has changed in 2014. So now if you are doing nuclear medicine physician training, as Charlotte said, you become dual trained and dual CCT'd in both clinical radiology and as a nuclear medicine physician. And that wasn't the case when I started. So if you were a nuclear medicine physician, you didn't automatically get trained in radiology as well. And I think that's been a fantastic adaptation and evolution of the training, and a lot of that is down to Charlotte and the work that other consultants within the training program pushed for, because we've moved from plainer sort of fuzzy images that traditionally people think about when they think about nuclear medicine from the 80s and 90s into functional hybrid imaging, where you have the CT or the MR components, you're fusing it with the nuclear medicine components, so you get twice, if not more times information, and you need to be able to look at both in their entirety and also compare with the other cross-sectional imaging that's available. So having that radiology background is super helpful. It does mean the training can feel quite long, but if you think about the fact that you are going to be a doctor for a considerable number of years, decades, actually those 6 years that you're training within your nuclear medicine physician program, plus the MRCP and IMT training that you'll be doing, that is a fairly small part of your entire career. So it is worth it. This is very rewarding. It is a growing specialty. Again, as Charlotte's talked about, the theranostic aspects and the development of new tracers only means that we're going to be more busy in the future. And having come from talks yesterday at the British Nuclear Medicine Society autumn meeting, where we were talking about artificial intelligence, I don't think nuclear medicine is a prime target for artificial intelligence at the moment. So I think we've got another few years before we're replaced by robots, and I think that's the case in radiology as well. But the therapeutic aspect allows patient contact, will not be replaced by artificial intelligence, and will allow your medical training and probably some of the reasons why you went into medicine in the first place to be maintained, with that therapeutic option where you are treating patients and you see the difference that treatment makes. The diagnostics is brilliant. It gives you challenges. Also, again, if I'm being very honest, you get to work from home if you're doing the diagnostics as well, potentially, depending on your job plan and your trust, in that it's all digital. So you don't necessarily need to be on site to do that. And I'm lucky that I have 1 day a week where I'm rotated to be from home, which allows some flexibility in terms of sort of the work that you do and when you do it. So it is a hard job, but it's very rewarding, and you do get to work not just with doctors, but with a huge number of other craft groups. So I can't work alone. It is not an individual sport. It is definitely a team sport. So I work with physicists, I work with nurses, I work with technologists, radiographers. You have to work very closely with your oncology colleagues, with your endocrine colleagues, because although, as Charlotte says, we have admitting rights again, depending on your trust, you receive your referrals from other clinical specialties. So you have to coordinate and collaborate with your clinical colleagues to help support these patients in their patient management and their follow-up and their assessment ahead of treatment. It is only going to get busier, I think, as time goes on. We are developing sort of smarter ways of imaging. We're developing smarter ways of looking at how cancers behave, and the theranostics aspects and the treatment will only increase as more tracers come on board. So we've talked about lutetium PSMA for prostate cancer, and there's the potential for something called actinium-225 PSMA, which is another PSMA-based tracer. So PSMA stands for prostate-specific membrane antigen, expressed on the outside of prostate cancer cells, but we also now can image, again, not in the clinical setting, it's still in research at the moment, but Herceptin receptors for breast cancer. So that is another huge sort of population that we may be able to help. And it's not that we're going to be treating everybody with breast cancer or everybody with prostate cancer, but being able to offer these treatments for particular patients, looking at the imaging, selecting them appropriately, is only going to be beneficial for these patient groups. And then we'll find more receptors, or we'll find other ways of targeting cancers and non-cancers. So the development of tracers looking at dementia, development of tracers looking at myocardial perfusion or hypoxia, renal function, etc., etc. So becoming able to look at these tumours, these pathological processes non-invasively is really exciting. So it keeps you on your toes in terms of sort of intellectual stimulation, as well as sort of work-life balance from that point of view. So you do need to be mindful of looking after yourself. You know, if your cup is empty, you can't help fill up somebody else's. So you do need to look after yourself and be sort of mindful of burnout. But the fact that it's such a rewarding job means that you get to work with lots of people who do help support you. You're not isolated, you're not on an island, and you get to do lots and lots of new challenging things and get to see people at the conferences like BNMS yesterday. So the British Nuclear Medicine Society covers a huge number of craft groups. Again, the physicists, radiopharmacy, nurses, oncologists, endocrinologists, doctors, not just consultants, but trainees as well. And because, as Charlotte says, it's a small specialty, you get to counsel and to join training committees, etc. Talk to you, so you get those interactions that maybe in a bigger specialty you'll never meet the respiratory physicians who are in a hospital even 50 miles away, let alone 150 miles away. So it is a really excellent career, even if I do say so myself, because I'm still doing it and I'm really, really happy. But I think Sweni and Hesham are probably going to give you the biggest insight in terms of what the training particularly entails at this point in time in the 21st century, rather than sort of when Charlotte and I were thinking of starting out a few years before that. But I will put in the chat my email address if it's not already been made available. So I'm amy.eccles@nhs.net if anybody else wants to talk to me about things offline. But otherwise, I think Hesham and Sweni are going to take centre stage and talk about training in the present.
Thank you, Charlotte and Amy. So as I said, my name is Hesham, just newly appointed as a consultant, and I want to speak about my experience over the last 3 years as a trainee. So hopefully that will give you some insight of what to expect during the training. I'm trained in Glasgow, which cover a large area in central Scotland and west of Scotland. We do a variety of examinations. So in regard of nuclear medicine, we do a lot of planar and SPECT nuclear medicine study, and we do PET-CT, mainly FDG and gallium dotatate. We do a lot of therapies, including benign and malignant thyroid cancer. We do also neuroendocrine treatment, radionuclide neuroendocrine treatment, and we were also involved with PSMA trials for therapies. I would say the first thing you need to ask yourself, if you are considering nuclear medicine as a specialty, do you enjoy challenges or not? If you enjoy challenges, and this would be the specialty for you. Challenges will be, you will be faced by challenges throughout the training and as a consultant, which will keep you intellectually stimulated. So as Charlotte said, it's a long training program and involves a lot of the exams. Some people might hate it, but doing the exams does help you to learn a lot. Knowing the theoretical basics, including physics and anatomy, about different organs and body systems will help you a lot in radiological and nuclear medicine imaging interpretation, and will make your life much, much easier in the future. People in the previously used to refer to nuclear medicine as unclear medicine, but this is no longer the case. Currently is actually the other way around. Frequently you will get cases where things are unclear in images such as CT and MRI, and they become only clearer when they get imaged by nuclear medicine modalities. So it provides additional physiological and pathophysiological information instead of just anatomical information. The training itself is 6 years. The first 3 years you will be doing 80% radiology and 20% nuclear medicine. The main focus in the first 3 years, I would say, is to get a good radiological training, pass your FRCR exam, get competent in especially emergency radiology, as you will be involved a lot with radiology on call. And from the nuclear medicine, you are expected to gain experience, especially in basic planar nuclear medicine and SPECT nuclear medicine. In the final 3 years, after you have passed the FRCR, you will start either a postgraduate diploma or a master's degree in nuclear medicine. This will provide you again with very useful additional information in regard to your day-to-day practice and future imaging interpretation. And if you want to involve with therapies, it will give you a lot of useful information that would help you in your future consultant as a in the future job as a consultant. These final 3 years, apart from the MSc, you will be doing mainly nuclear medicine, 80% nuclear medicine and 20% radiology. The 20% radiology tends to be general radiology and acute radiology. You will also be expected to provide some service covers such as plain film reporting and ultrasound reporting. The nuclear medicine, at least in my training in the final 3 years, I used to do clinics, including benign thyroid clinic, malignant thyroid clinics, and neuroendocrine therapeutic clinics. I was also involved a lot with MDTs. Any MDT that involves PET scans or nuclear medicine imaging, I tried to get involved in these MDTs, especially lung cancer, neuroendocrine MDT. And also the other things is PET imaging. So you will be heavily involved in PET imaging for various either oncological indications or non-malignant conditions. Other aspect of nuclear medicine I was involved in the last 3 years is nuclear cardiology. I did enjoy it a lot. You would work with cardiologist, you would work with technician. Normally you will come in the morning, perform either pharmacological or physical stress to the patient, and involved with imaging and imaging interpretation. So it was very nice experience. This is good for some people who like to maintain patient contact. Patient contact is also maintained throughout the clinic and in the ultrasound sessions. In regard to challenges of the specialty, I would say mainly it's a long training pathway, involves a lot of the exams. But again, I found it, although sometimes at sometimes it could be stressful, but intellectually stimulating, and it pushed me more to try to achieve more. It's a small specialty, but the good thing about it is you get to know everyone all over the UK in a very short period, because it's a small number of consultants, small number of trainees, so we know each other. Although we don't meet a lot, but when we get into meetings, we will find like, oh, I've already communicated with this person, asked for an advice or something else throughout email. And the other thing is some training centers, they don't have experience or they don't provide all imaging modalities that are required in the curriculum, and provided because it's a small specialty, it's easy to communicate with other centers to sort out the experience in that particular imaging modality that is not available in your training center. I think this is all what I have to say. But if you have any questions, I'm happy to answer. If not, I will pass on to Sweni.
Thank you, Hesham. I think all of you have covered quite a lot and in detail, but what I want to talk about is a bit different to what has been covered so far. So I'm just going to talk you through about what exactly my training was like so far. So basically, for the first 3 years, as has already been mentioned, it was mainly based on radiology. So 4 days a week used to be in radiology, 1 day a week in nuclear medicine in my first year. I am at one of the biggest nuclear medicine departments in Northwest London, apart from where Amy works, but I also work in a very big center at Royal Free, and we are a big amyloidosis center, a big neuroendocrine tumor center. So we perform a lot of therapies, but also a lot of diagnostic work, most of which it has now changed to hybrid imaging, SPECT CT, and very little of our work is planar imaging. So when I started my radiology training, and this is how the radiology training here at Royal Free works, but every center is going to be different. So your training, both in radiology and nuclear medicine, will be very different, and it will be tailored according to the place where you work. But just to give you an example of how exactly my training was, so in our first year, radiology is broken down into various blocks. So it's an ultrasound block where you almost do ultrasound every 3 days a week to just get used to doing ultrasounds. So that will be 2 or 3 months, and then you'll be signed off to do your ultrasounds independently, especially just the abdominal and pelvic ultrasounds. So we have 4 blocks in our first year in radiology, which is ultrasound, fluoroscopy, which is barium to perform swallows. Again, by the end of that block, you will be signed off to do them independently. CT block. So CT block, as a first year, you are basically trying to learn the anatomy around the CT and maybe start reporting basic CTs, and all of the CTs will be checked, whether it's an acute inpatient/emergency CT or an outpatient waiting list initiative CT. And the fourth block was interventional/neurology block, where you start getting used to how you would do biopsies, etc. So that's how the training for radiology trainees in our department, in our hospital works. But every place is different. At some places, I know it's block-wise, as in GI block, MSK block, etc., etc. But here, this worked well for us, because then by the end of these blocks, ultrasound and CT, etc., by the end of first year, we felt very confident in our skills. And in London, even though you are based at a tertiary care, your base hospital would be a tertiary care centre hospital. From a radiology point of view, you would rotate through various smaller DGH hospitals, which may or may not be a part of your trust. So I rotated through other hospitals in my second and third year for my radiology training. But for my 1 day a week of nuclear medicine, I used to come back to Royal Free, which is my base hospital, because the nuclear medicine is the training is mainly based in a tertiary care center. So I was appointed by 2 hospitals at the same time in my second and third year, where my radiology training was in a DGH, but my nuclear medicine training continued here at Royal Free. So in terms of what did I do in my 1 day a week of nuclear medicine, it was mainly, because in the first year you have to pass your FRCR Part 1 exam, which is anatomy and physics. I was in nuclear medicine, my consultants wanted me to basically pass my exams. So we used to do 1 session a week of PET-CT, so that I started getting used to all the cross-sectional imaging, etc., and 1 session a week of general nuclear medicine. The biggest advantage, having come from core medical training, obviously it's now IMT, but it was CMT when I did my medicine training, was that all my scans from day 1, whatever I reported, was always checked by a consultant, and I always got feedback on this. So it's very different to the training I received during my IMT years, where most of the work, or CMT years, was that where most of the work I never used to get like particular feedback on how I did with an individual patient, or whether my management was good, how I could improve that management. But here, on every scan that I reported, I used to get feedback. Every morning we used to have teaching in radiology, and I mean, we still do if we want to attend, but now that I've moved to my nuclear medicine part of training, I don't attend that teaching, but there's teaching every morning from 8 a.m. to 9 a.m. And I am, as far as I know, this is throughout most London training programs, that there's teaching every day from consultants, which is very different to what I had received in my core medical training years. So it's so rewarding to be able to come into a specialty where people take your hand with you and they kind of teach you on a daily basis so that you can improve on your knowledge. It was really satisfying when I came into this as a first year. But apart from that satisfaction of being taught every day, learning new things every day, I also felt scared, because having come from CMT, I had forgotten all my anatomy, and post my CMT, I did research before coming into training in nuclear medicine. So I had forgotten all the anatomy, and I was like, okay, there's so much to learn, and physics obviously was as well. But if you are sure that this is the specialty for you, that is radiology and nuclear medicine, then it's not hard. Yeah, it does demand a lot of hard work. But it was really rewarding to be able to learn every day and then put it to practice and get feedback on it. By the end of first year, at most London training programs that I'm aware of, I don't know much about outside London, you get signed off to be able to report your plain films independently, and you also get signed off to be able to preliminarily report all your CTs when you're on call. The way on calls work in radiology here is you do in your first year you are with another senior trainee, so you're just mainly answering all the bleeps and maybe vetting and protocoling scans, but you can also chip in and report scans, which are always checked by your senior colleague. And then once you start from your second year, once you go off to the DGH hospitals, you do your own preliminary report. And then from the third year, you come back to your base hospital, that is your tertiary care center, and then you're on the senior on-call rota for radiology. And I'm still on the on-call rota for radiology, and you continue doing so until UCCT, despite being on your 3 years of nuclear medicine training. So even though I've switched over to my 3 years of nuclear medicine training, and I am in my final year of nuclear medicine training, I still continue to do radiology on calls. In terms of radiology on calls, that will vary depending on the center where you are working. Some places will have night on calls and weekend on calls, whereas some other hospitals may outsource their night on calls, and registrars might be on call only until 8 p.m. or 10 p.m. So it depends on which training program you get into, but no matter where you work or where you get into training, at the end of it, you will be competent in your CT /MR on-call skills. So that's not an issue. The other advantage, apart from the teaching that you receive departmentally, you also have deanery-led teaching, both for radiology as well as for nuclear medicine. So yes, during my CMT years, I had deanery teaching, but this is very different because here I was taught every day. So that was my first year of training. Second and third year of training in radiology were very similar. You just kind of do blocks. So you do an MSK block where you would get more training on doing MSK specific imaging. You do a GI block where you get more training on doing GI specific imaging. Thoracic block where you report a lot of CTs, mainly chest for lung cancer, etc., but also for interstitial lung disease. So that will vary depending on which kind of blocks you do and where you are working. So by the end of third year, you are on the senior on-call rota here and in most London hospitals, and I think most hospitals even outside of London, in terms of your radiology training. And you give your FRCR Part 2B, which is a VIVA exam, similar to the MRCP PACES exam, in terms of it being a VIVA or a practical exam, in the beginning of the fourth year. When I changed to my fourth, fifth, and sixth year, that is my 80% nuclear medicine block, the challenge was to be able to fit as much as I can into my 1 day of radiology training. So that was mainly one CT session, and then the other session could be an ultrasound. So if I'm doing ultrasound, then I can't report MRs or plain films, or if I'm doing a CT session and an MR/plain film session, then I can't do ultrasound. So that's a challenge about how much time and effort you want to put in, and how you can work well with your rota coordinator, and how much service requirements are required from yourself in terms of being able to manage that. But it is all manageable, but it is, you do have to put in that hard work. In terms of what I do in my 3 days in my 80% nuclear medicine, it's a variety of stuff. So general nuclear medicine versus just PET CT imaging. And then here at Royal Free, we don't have any clinics for our therapy patients. It's all discussed in an MDT, and we consent the patient on the day they come in for their therapy. For thyroid, malignant or benign, we do a pre-therapy consultation, which is just in one of the rooms here. We don't have a specific clinic for that. And once we've done the therapy, the particular specialty. For example, for thyroid, it is taken over by the endocrine team. Once we provided the therapy, the patient's care is taken over by the endocrine team. If it's a neuroendocrine team, the care transfers to the NET service. If it's a PSMA therapy patient, then the care transfers to our uro-oncologist or urologist. So from that perspective, we actually don't have any clinics here. But in terms of my therapy training, we also do therapy. So in terms of my therapy training, that involves mainly attending MDTs and consenting the patient on the day of the therapy, administering the therapy, and then just kind of handing over back the patient to the relevant specialty. So that's very different to the kind of training that Hesham has received, where he's done clinics. So that will again depend on the center where you're working. The other thing why my training was a bit different compared to Hesham in terms of nuclear medicine. We are a very big nuclear medicine center. We do all kinds of studies here. But because London, that is the advantage of London. All hospitals you can easily travel to different hospitals within London. So I had the ability to be able to arrange specific kinds of taster or experience weeks with very super specialized hospitals. For example, the Royal Brompton Hospital is very, very specific and specialist in nuclear cardiology. So we do nuclear cardiology here. We do stressing lists, etc. here. And we have patients that I had enough experience of reporting those scans here. But because Brompton is a specific nuclear cardiology center, my consultants were happy for arranging a 2 or 3 week block for me to go and attend and get that specialist experience. And with me, there was another trainee. And because we really liked our block so much, we in fact extended it and we said, we are getting a lot out of this, so can we do a 1 month block? And we ended up doing a 1 month, whereas initially it was planned as a 2 week. Similarly, Royal Marsden is a very big oncological hospital, and they do and administer therapies very different to how we do it at Royal Free. So again, we arrange for a 1 week block there to see how differently they perform their therapies and how they manage their patients. Similarly, Great Ormond Street Hospital is a very big pediatric center, and I'm due to go there to get experience in pediatric nuclear medicine imaging. Although we do perform pediatric nuclear medicine imaging here, it's just to kind of get that specialist center experience. So this is the advantage of being in nuclear medicine. Hesham already said that because everyone kind of knows everyone, it's a very small specialty. So it's very easy for my consultants or my education supervisor to be able to email someone in that hospital and say, oh, can my trainee come here? And like we don't do thyroid clinics here, so they've arranged for me to go to Guy's and St. Thomas's Hospital to be able to get experience of how therapies are run in a clinic kind of a center, how they perform their thyroid therapies different to how we perform, etc. So it's a very dynamic kind of training in terms of how you can tailor your training. For example, if you were interested in nuclear cardiology, then they could have arranged for me to have a 6-month session there, obviously after getting permission from the National TPD. So that's basically all what I wanted to say about how my day-to-day training entailed. In terms of the challenges that I face, you have to be aware, because it's a dual CTT program, you will have 2 ARCPs. For the first 3 years, your ARCP will be led by radiology, but you will have to satisfy the requirements of the nuclear medicine. So you will have to have enough assessments, both from your radiology perspective, but also from your nuclear medicine perspective. And then in the last 3 years, your ARCP, although is led by nuclear medicine, you still have to maintain the requirements in radiology. So that is challenging. The other challenges are, as far as I know, it is one of the longest training program. I mean, there might be some surgical programs that are longer, but if you count into being the amount of time you spend as a foundation doctor, as an IMT, and then then as a trainee on the 6 years training program, then that's a significant amount of time. But as Amy already said, it is very rewarding by the end of it. You get dual CCT. So what you want to do in your job plan as a consultant, you will have a wide range of opportunity, and you will be able to select well what you want to do and how you want to do in terms of your job plan. But it is one of the longest training programs, and that is a challenge because you are trainee for a significant amount of time. There are loads of exams, and by the time you come into nuclear medicine, you would have already done your MRCP or equivalent MRCS or MRCP pediatrics. But you will again have to start with the FRCR Part 1, Part 2A, Part 2B. Then once you finish your FRCR, you have to enroll into a PG diploma or MSc in nuclear medicine. So again, that has a lot of modules, and there will be exams and essays for that. Apart from having said that yes, you will have to prepare and you'll have to study for these exams, you do end up getting a significant amount of knowledge from these exams. So it is a challenge to be able to take that time out, to be able to study for these exams while working full time in two specialities, both radiology and nuclear medicine, and whilst balancing your on calls. For example, at Royal Free, we do night on calls as well. So whilst balancing your, work-life balance around it. So those are the main challenges. But why I like the specialty and why I would recommend anyone to get into it is it is a very personal choice. For me, when I did my CMT, by the end of CMT, I would say I was probably on the verge of burnout. I hated moving around and running around the hospitals during my own calls in the middle of the night. And post that's why I took up a research job where I just didn't want too much patient contact. I had patient contact, but I also wanted a job where I was sitting behind a computer and making decisions, etc. So when I did my research job for 2 years, I realized that, this is something for me. I want to be able to help make diagnosis, give treatment, but I also don't want constant patient contact. And that helped me make the decision of coming into nuclear medicine. I really like technology. I really like the constant evolution of nuclear medicine. Since I have been a trainee, so obviously it's a 6-year training program, but I also had a maternity break. So I've been a trainee now for 7 years since I got into training. And even since I've come in, I've seen new developments, like PSMA therapy wasn't there when I came in first. Similarly, choline PET CTs for parathyroid imaging was not there when I first came into training. When I first came into training, we used to perform choline PET CTs for prostate cancer, but that changed to now to PSMA imaging for prostate cancer. So even whilst I've been a trainee, I've seen this evolution. So imagine what the future is going to bring. So it's constantly evolving, constant learning, and that's what has been most rewarding for me.